the present scenario regarding these screening procedures for the malignancy. Thank you, sir. And let us wait for a few more minutes. The Honorable Vice Chancellor will be joining you all. And ಇದ್ಯಾರು ಇವ್ರು ಆರ್ಗನೈಸ್ ಮಾಡಿದ್ದ ಮೀರಾ ಅವರ few more minutes, sir. Honorable Vice Chancellor will be joining us shortly. Thank you.
So what cancer allowed?
Cancer screenings. CN Patil, consultant medical oncologist, will be speaking on cancer screening and saving lives. He has changed it to current evidence. He has changed it to current evidence. He has changed the title to cancer screening and current evidence.
Okay. On ಇದೆಯಪ್ಪ Good afternoon. This is Dr. Sachidanand, Vice Chancellor, Rajiv Gandhi University of Health Sciences. I welcome all the participants for this continued medical education lecture series being arranged as a part of 25th year celebrations of Rajiv Gandhi University of Health Sciences. This is the fourth lecture in the series of lectures. And Rajiv Gandhi University of Health Sciences, as you all know, has been a pioneer in all academic activities. Academic excellence is the mantra. We always look at things where creation of an academic culture in each and every affiliated college is what is the motto. And to this effect, we have also been doing a lot of research activities over a period of 4-5 years, and the results are bearing fruit now. As all of you know, non-communicable diseases is a big bane for this country, especially India, with more than 20 to 30% of the population suffering from these non-communicable diseases, with the diabetes being the main killer. Communicable diseases was the earlier bane India was facing. Even in the presence of communicable diseases, non-communicable diseases become more relevant now. Diseases like hypertension, diabetes, myocardial infarction, and cancer are playing a big role in the mortality and morbidity of the patients that we see in our regular hospitals and OPDs. Today, we have diseases like CN Patil, consultant medical oncologist, Apollo Hospital, Bangalore, speaking to us on cancer screening, current evidence, which is the most relevant topic, probably an evergreen topic, relevant at all times. And I'm sure all the delegates, all the participants who have logged in would benefit immensely and have several take-home messages to improve their practice. I hand over the podium to Dr. Meera to introduce the speaker and the topic as well. Over to Dr. Meera.
Thank you, sir. Thank you so much. And it is my proud privilege to welcome Dr. C.N. Patil for the webinar session. And let me introduce Dr. C.N. Patil, sir, to the viewers. He did his MBBS from Mysore Medical College, Mysore, and MD from Kasturba Medical College. And he did his medical oncology, DM Medical Oncology from Cancer Institute, Adyar, Chennai. And it is a proud privilege for all of us to know that he has got a DM. Congratulations, sir, from all the viewers' side and from RGHS side. And he has got many awards and prizes. and he stood first in medical quiz organized by the Association of Physicians of India at Shumaga, held at Shumaga in India 2004. And he got second prize subsequently in this association was organized at Tumkur, India 2005. And he has got second prize in oncology conference held at Bhubaneswar, India 2008. That is for the debate. And he is a Best Outgoing Student Award. He has received Best Outgoing Student Award India 2009 from Cancer Institute of Adyar, Chennai. And he has got a wide and vast experience in his field. And his specialty is breast and ovarian cancer and also stem cell transplantation. And he has got many national and international presentations and publications. And sir, we are very honored to have you here. And it is on the event of 25th Silver Jubilee occasion of RGHS. And we'll welcome you. And over to you, sir. Kindly take over the session. Thank you so much.
Thank you so much for the kind introduction. That's Dr. Sachidanand sir.
He didn't tell me about it.
Ramakrishna Reddy sir. Dr. Meera S. Professor in Biochemistry and Postgraduate Board of Studies. Dr. Rayas, Deputy Director of RGHS and the leader of this event, for giving me this opportunity. And it's a commendable job in these difficult times, COVID times, organizing webinars. And today I'm asked to speak about cancer screening, early detection saves lives. We shall go through the current evidence what we have in cancer screening. And during
Sorry to interrupt you, sir. Sir, can you please make the slide share screen enlarged, sir?
Slideshow.
Slideshow. You please make it slideshow, sir.
yes, sir.
Yeah.
Is it enlarged? Sir?
Yes, yes, sir.
It is. No.
I've been asked to speak on the cancer screening current evidence, what we have and whether it saves lives in our day-to-day practice. In our day-to-day practice, we just generally come across cancer patients who are diagnosed in advanced stage, where nothing much can be done, and we end up offering best supportive care or palliative chemotherapy. So often this question is asked whether cancer could have been detected early, and is there any benefit of detecting it early? And what are the cancers that can be detected early, and how to go about screening in India, and whether it saves lives, and what is the evidence that we have today regarding cancer screening. So whether the first question is whether cancer screening is relevant and important in India. So we'll answer this question after seeing the data. Burden what we see in developing world or developing countries like
You are now
India.
unmuted.
And coming to the
You are now muted.
Indian scenario, there is an IARC estimation that 635,000 people died from cancer in 2008. And in India, 8% of all estimated global cancer deaths and about 6% of all deaths occur in India. And the rates are expected to rise because of population growth and increasing life expectancy. So that should answer our question whether cancer screening or early detection is important in India. Because of the huge burden what we have and the huge population what we have, and with the increasing life expectancy, and as Vice Chancellor sir told in the beginning introductory talk, that communicable diseases were the previous bane, and now non-communicable disease has become the bane of Indian society. So it is important for us to know what are the cancers which can be screened and what are the cancers which we can detect early and prevent deaths and have a longer life. So let us see the history of screening, how it started and where we are today. History started way back in 1940s, where George Papanicolaou started pap smear for cervical cancer detection. And breast cancer screening started in 1960s. Even though it started 6 decades ago, There is still controversy regarding breast cancer screening, whether mammogram should be done or should not be done, and what age should the mammogram be offered. So there are a lot of controversies in breast cancer screening. So we should go through that, the evidence what we have and what can be done from our side. And lung cancer screening trials are conducted as early as 1970s, but even today, we do not have conclusive evidence about lung cancer screening. And the first colorectal cancer screening trial was started in 1975. That was almost 6 decades ago. And we have a set standard guidelines for colorectal cancer screening. That's how the cancer screening history started. And first, before we go into the cancer screening, we should know something about the principles of screening, which we all of us have studied in our Park and Park in community medicine. For screening, a disease should be an important public health problem. And fortunately, in India, cancer is not a public health problem. Even then, because of the sheer population we have and the burden of cancer what we are seeing, it becomes important for us to know what cancers can be screened and whether it can be included in the national program or we should do it as an opportunistic screening what we are doing now. But fortunately, the first point is not met by the cancer. That is, it's not an important public health problem in India because the incidence of cancer in India is 1 in 1,000 or 100 per 1 lakh population. Whereas if you see in the Western world, it's around 400 per 1 lakh population. But if you see the absolute numbers, because of our sheer population, it becomes a huge number. So even though it's not a public health problem, there are areas where we can implement screening in cancer in India. And what is the next point that should be met? The screening interval must be shorter than the detectable preclinical phase. Cervical cancer is the best example for this point because the preclinical phase is longer and it gives us enough time to detect the cancer. And what is the next criteria that should be met? The next criteria is there should be an effective treatment available for the cancer which we have detected. Suppose we detect a pancreatic cancer and there is no effective treatment for that, and then there is no point in doing screening. So this criteria is very important. And the test, regarding the test which is employed for screening to detect cancer, it should be accurate, it should be acceptable, it should be easy to administer, it should be safe and relatively inexpensive because we are talking in terms of testing normal individuals and not diseased individuals, and we are talking in terms of addressing the population at large. So the test should be safe, inexpensive, and easy to administer and acceptable by all. And there should be an appropriate strategy for the target population based on the disease incidence, and it should be based on good scientific evidence. So these are the criteria that should be met before we embark on screening. And what are the biases that we encounter when we do cancer screening? There could be selection bias. If people who are health conscious and then they only come for screening, then it leads to a selection bias. But we are talking at applying screening to a larger population and population at large. So we should not be looking at selection bias. And there can be lead time bias. The early detection falsely makes it look like that people are surviving longer. So we may be detecting innocuous cancers, which are not a threat to the life at all. And that may give a false impression that people are living longer just because of our screening. And what is length time bias? We may overestimate the survival duration due to relative excess of cases detected that are asymptomatically and slowly progressing. So the disease may not be symptomatic at all, and it is asymptomatic or slowly progressing, and we detect them and can come to a conclusion that people are surviving longer. So that is overestimation of the survival duration. That is length time bias. So these are the biases which can be dealt with during screening. So we should know the criteria for screening. It should be an important public health problem, and the screening interval must be shorter than the detectable preclinical phase. Effective treatment should be available once we detect the cancer, and the test should be accurate, acceptable, and easy to administer, and it should be safe, relatively inexpensive, and there should be an appropriate strategy for detection for the target population, and it should be based on good scientific evidence, and also the bias which we have discussed. So coming to the randomized control trials for cancer screening, like we have for any treatment modality, they're expensive and take considerable time to complete because we are looking at population testing and the testing can be expensive and it may take a long time for them to be completed and come to a conclusion. So these are the difficulties we face in doing cancer screening studies. So coming to the particular cancers where there is benefit of screening and whether the cancer screening has saved lives, we shall look into each of them. The first and foremost is breast cancer screening. So there are three methods of breast cancer screening. One is breast self-examination or clinical breast examination and mammogram. So what is the evidence that we have for breast self-examination? Generally in the clinical evidence, the efficacy of breast self-examination is unproven. And it should only be performed as an adjunct to mammography and clinical breast examination. So there is no strong evidence to advocate breast self-examination. However, in India, we see patients coming with larger lumps and they present in advanced stage. So it is worthwhile to teach women the breast self-examination, and which will be done every month on the 10th day of menstrual cycle. And then they'll know what to be brought to the notice of the clinician and what should be addressed. So that is the importance of breast self-examination, whereas as far as India is concerned, but if you see at the scientific evidence, there is no strong evidence that it has saved lives or it is not recommended at all in all the recommendations of screening. However, we can encourage our population to do breast self-examination every month so that at least we can detect them at an early stage, because we see T4B where the pudgy orange is already formed or more than 5 centimeter tumors, which is very unfortunate. So the detection rates are very, very low because of the reluctance of the females to come for clinical examination once they detect a painless lump in the breast. So it should still be encouraged even though we do not have a strong clinical evidence as breast self-examination as a screening tool. So what is the evidence that we have? Women between the ages of 50 and 70 should be screened with mammography. See, mammography is a very useful tool which is widely available, but we do not have it in remote areas like rural areas. So that is the difficulty, and it cannot be employed on a population basis. And there are a lot of controversies surrounding mammography, whether it should be offered after the age of 40 or before the age of 40. There is definite no before the age of 40 because the breast is dense and the information what we get through mammogram is minimal, and it should not be done before the age of 40 years. And 40 to 50 sonomammogram can be advocated because the breast is relatively dense and it is still worthwhile to do a sonomammogram. Whereas after the age of 50 years, that is from 50 to 70, we would recommend a mammogram, annual mammogram for all individuals. And the ideal interval, what should be the interval between two mammograms, ideally is not known, but it is suggested to screen every 1 to 2 years. And if 3 consecutive mammograms are normal, then it can be relaxed to once in 2 to 3 years. So that's what we have evidence, but that's a very weak evidence, grade 2C recommendation what we have, the interval regarding the interval. Whereas for the mammogram as a screening method between the age of 50 to 70 years, it is grade 1A recommendation. And women being screened for breast cancer should also undergo clinical breast examination, that is once a year. So this is the recommendation for the general population. What about the population who are at high risk for breast cancer? The lifetime risk, if it is more than or equal to 20 to 25%, they should be referred for genetic counseling to determine the likelihood of a BRCA mutation and to decide on management options. Here the recommendations are not similar to the general population what we have. We may have to start the cancer screening at an earlier age, and we may have to reduce the intervals to once in 6 months. And alternatingly, mammogram and MRI of the breast can be employed to detect breast cancers. And they should be referred for genetic counseling, and then only thorough decision has to be taken. So this is only for the small set of population, that is 5 to 10% of population. Whereas for the remaining population, annual mammogram after the age of 50 up to the age of 70. And if 3 consecutive mammograms are normal, it can be relaxed to once in 2 to 3 years. There is no strong evidence to say that breast self-examination is a good screening tool. However, clinical breast examination along with mammogram, annual mammogram, should be advocated. This is how a mammogram looks like. Whereas florid cancer will have a speculated margin, and by the time we detect that, it's already late. Whereas the mammogram can detect speculated speckle calcifications, which can detect in early stage, that is in the pre-invasive stage, that is in situ carcinomas can be detected in mammogram, and that's the advantage of mammogram. And that should be properly interpreted and employed. So this is the cartoon showing the relative risk reduction and the age at which the screening should be started. As you can see, at the age of 30, there is no risk reduction, and mammogram or screening should not be advocated. Maybe we can teach them to do self-examination. Whereas from the age of 40 onwards, there is controversial evidence, 40 to 50. After the age of 50, there is definite absolute risk reduction of 1.9 to 3.9 per thousand population, and we need to screen them annually. And after the age of 70, there is no strong evidence, so it is not recommended beyond the age of 70. So this is as far as breast cancer screening is concerned. Coming to the colorectal cancer, which is another important cancer which can be screened, and the evidence what we have.
Volume maximum, volume maximum, volume maximum.
So the evidence what we have for colorectal cancer, we shall see that. And the screening has been shown to decrease mortality from colorectal cancer. And average risk patients, that is people aged 50 or older, should be screened for colorectal cancer. There is a grade 1A recommendation. And what are the screening methods we have for colorectal cancer? Colonoscopy every 10 years is the optimal recommendation for colon cancer screening. And nowadays it is done safely and without much complication. And the risk of perforation is only 1 in 10,000. And it's a good tool to screen the entire colon. And the computed tomographic colonography every 5 years is also recommended, but the strong recommendation is for colonoscopy every 10 years. And flexible sigmoidoscopy every 5 years can be recommended in certain group of population, but the entire colon can be screened with colonoscopy every 10 years. And the alternatives that are suggested are annual stool testing with GUVIAC or immunochemical reagent, but they are not acceptable to the population and can be cumbersome and difficult to employ for the population. So the best method to screen colorectal cancer is colonoscopy once in 10 years, starting at the age of 50. So if we practically see, an individual can may be required to undergo 3 colonoscopies, that is at the age of 50, at the age of 60, and at the age of 70. So this is what is recommended for colon cancer screening. And it is known to increase the survival and decrease mortality. And the other alternative tests are not acceptable and not widely followed. This is for the general population. So what is the recommendation for population or people at sufficiently increased risk? If they have a personal history of colorectal cancer, or if they have a family history, strong family history of colorectal cancer, or adenomatous polyp, or if they have a genetic syndrome predisposing to colorectal cancer, that is hereditary non-polyposis colorectal cancer, or familial adenomatous polyposis, or if they have 1 or more first-degree relatives with colorectal cancer, what is the recommendation to do colorectal cancer screening? In those individuals, and also with individuals with 2 or more second-degree relatives with colorectal cancer, or if they have an inflammatory bowel disease causing pancolitis or long-standing active disease if they have with ulcerative colitis or Crohn's disease, or if they have a personal history of childhood cancer requiring abdominal radiation therapy. So in those individuals, the screening interval is shorter, and the screening should start 10 years earlier than the index case what they have in the family. And the interval is once in 3 years or once in 3 to 5 years colonoscopy. And any suspicious polyp or adenoma should be biopsied. So that is the recommendation for people at high risk. And again, as in breast, this is only catering to 5 to 10% of all the colorectal cancers, whereas 90% of the cancers or 80 to 90% are sporadic, and the recommendation which is good for population holds good. And this is the cartoon showing the complexity of the test and the sensitivity and effectiveness of the test, which if we take overall picture, fecal occult blood test, fecal immunochemical test, flexible sigmoidoscopy, and colonoscopy, the test sensitivity and specificity is highest for colonoscopy, even though it's complex, and the effectiveness is highest. And the screening detection is maximum with colonoscopy. But unfortunately, this cannot be employed in a population like ours because of the sheer number, and also we do not have the infrastructure and expertise to do colonoscopy for all people who are above 50. So that is the limitation of colonoscopy. But if somebody has a family history and somebody wants to get tested or wants to know the risk, colonoscopy is the recommended test after the age of 50. And if it is normal, it can be repeated only after 10 years. We do not have to repeat it early. So that is as far as colorectal cancer is concerned. And coming to the cervical cancer fits all the criteria of screening which I mentioned earlier, except for the first criteria that it's not a public health problem. And fortunately, the colorectal cancer incidence in India is coming down because of improved hygiene, improved awareness, and also partly because of the vaccine which is available. And cervical cancer screening, it has the potential to detect precancerous lesions and prevent cancer. And what is the recommendation what we have for colorectal cancer, the cervical cancer screening? Women aged 21 to 65 years should undergo screening for cervical cancer. So the pap smear is the time-tested test with or without human papillomavirus co-testing, and that is time-tested and the standard which is used for cervical cancer screening. And pap smear has to be done once a year after the age of 21 or after sexual exposure, whichever is later. And if 3 consecutive pap smears are normal, then it can be changed to once in 3 years. So after they are sexually active, pap smear should be done, and it should be repeated after a year and one more after a year. And if 3 consecutive pap smears are normal, it can be done once in 3 years. And it can be with HPV or without HPV testing, but pap smear alone is good enough to detect early cervical cancer in an early stage, and it has shown to reduce mortality. Again, the test is not acceptable and difficult to carry out in the population because of the sheer number and the lack of infrastructure and expertise, and women do not come forward and get a pap smear done. But if somebody wants to know what is the evidence, pap smear should be done for all people after they are sexually active, and it should be done once a year. And once 3 consecutive pap smears are normal, it can be relaxed to once in 3 years. So this is the recommendation in different countries what we have and what frequency they do. And majority of them do at a frequency of 3 to 5 years. Initially, they do it annually, and then they do it once in 2 to 3 years. And majority of them start or recommend to start after the age of 20 to 21. So that's the recommendation what we have across the globe. So that is regarding cervical cancer. So we have covered breast cancer, colorectal cancer, and cervical cancer. These are the 3 important cancers which can be screened, and they are the standard cancers which can be screened and have shown to be detected early, and they have saved lives and they have decreased the mortality. Coming to the other cancers, whether we have to screen them or whether we have evidence to screen them, let us see quickly. Lung cancer. Lung cancer is the leading cause of cancer-related death, and prevention, that is promoting smoking cessation, is likely to have far greater impact on lung cancer mortality than screening. So screening in lung cancer is controversial, and even though it started 6 decades ago, there is no consensus on lung cancer screening, who should be screened and who should not be screened, what is the definition of heavy smoker, whether non-smokers or light smokers should be screened. So there is a lot of controversy regarding lung cancer. It is a rapidly evolving field, and annual low-dose CT screening in patients with a 30-pack year history of smoking is recommended nowadays, but it is very difficult to counsel these people and get them for screening. Coming to the prostate cancer, And although screening for prostate cancer with PSA can reduce mortality from prostate cancer, the absolute risk reduction is very small. And as I told you, this is the cancer which can have lead time bias and the length time bias, where we may be detecting innocuous malignancies which may not progress in their lifetime and just claim that the survival has been longer or the people are doing well. But they may be innocuous cancers and they may not be affected by the cancer at all in their lifetime. So that is the pitfall of prostate cancer screening. So, however, we do not have a robust recommendation for prostate cancer screening in the form of PSA or transrectal ultrasound. Coming to the oral cancer, which is a big problem in our country because of the smokeless tobacco what we use extensively, and what is the evidence for screening in oral cancer? In the trial population as a whole, the study group showed a non-significant 21% reduction in mortality from oral cancer compared with the control group. These were the screening tests done in India for cervical and oral cancer and published by Shankar Narayan et al. In 2006. And there was a significant 34% reduction in high-risk patients. So that's a well-conducted trial where they could do for a population and then come out with the conclusion that it reduced mortality, but it is very difficult and cumbersome to do in a larger population and to apply to the complete population as such. And this is how a precancerous lesion can look like. And if we identify a person with history of tobacco use and can educate them and to stop chewing tobacco at this stage, we can stop the cancer. And erythroplakia looks like this, and it is definitely pre-malignant and it should be addressed. And this is how a Barrett's esophagus looks like, and all of them are precancerous. So going forward, we should know the do's and don'ts before we advocate screening. So we looked into the evidence of screening what we have for various diseases like breast cancer, cervical cancer, colorectal cancer. These are the three cancers where screening has shown definite benefit. Whereas for lung cancer, it is experimental and it is evolving. Oral cancer, yes, in some areas, but it is not possible or feasible to do. And for oral cervical cancer, we saw, and oral cancer, its evidence is not strong. And prostate cancer, the evidence is not strong, even though we have a test called PSA to screen them early. And what are the do's and don'ts before we embark on screening? We should make an informed decision, and we should understand the sensitivity, specificity, and the bias of screening and the tests involved in screening. And we should always be looking at opportunistic screening in certain cancers, like lung cancer. If somebody is a heavy smoker, we can advise them lung cancer screening with a low dose annual CT scan. Or if somebody is using tobacco, that is chewing tobacco, and we can screen them for oral cancer. And if someone is coming for follow-up for diabetes or hypertension, we can always sensitize them for getting a mammogram done. But this is all opportunistic screening and not population screening. And what are the don'ts which should we know? The telling patient that you don't have cancer after some tests. And people often ask whether they can do a PET CT scan as screening to detect cancer. So that is not advocated at all. And labeling no cancer after a single test. Suppose you do a pap smear and then just label no cancer, that is also not right. We'll have to advise a mammogram and a colonoscopy for an individual after the age of 50 years. And doing serum markers for cancer screening. We do see sometimes people ordering CA125 or PSA and CA19-9. This type of tumor markers, AFP, beta HCG for cancer screening, they are not validated at all and do not have a role as a screening method. And screening and reassuring patients without advising on risk factors. That's what we saw in lung cancer and oral cancer. If somebody is a heavy smoker or is using tobacco heavily, we should counsel on prevention of cancer and also on healthy habits and avoiding tobacco rather than just screening and reassuring them and letting them loose in the population. So these are the don'ts which we should know before we embark on screening. So coming to the take-home message or the conclusion, we should know the principles and pitfalls of screening. Screening is a population tool. It's applied to the population, and when it is applied to individuals, then it can be an opportunistic screening. But when we are speaking of screening, it is for normal, healthy individuals and population at large. And we should know the principles of screening, where screening should be done and where it should not be done, and what are the tests which are available for screening, and what are the pitfalls of testing methods. What is the specificity of the test? What is the sensitivity of the test? What is the predictive value of the test? Positive predictive value, negative predictive value. First question which should be asked is whether it's a major public health problem. Second question which should be asked is whether the screening test can detect effectively. And the third question which should be asked is whether after detecting the cancer, is there an effective treatment for that? And fourth, whether it saves lives. So these are the principles and pitfalls of screening which all of us should know. And we should understand that screening is expensive and cumbersome. When we are speaking of screening for the population, it's a huge task. And for a country like India with heterogeneous population and a huge population, it can be quite expensive. That's why there is no standard recommendation in India for any cancer, for that matter, for screening. Because one is it's not a major public health problem. Second, it's difficult to apply in our population, and it becomes cumbersome, and the acceptability rate is very low. And even after motivation and education, people do not come forward for a pap smear or a mammogram. So that's what we should know about screening. And what is the survival benefit, what we have seen? That's the topic of discussion today, whether it has saved lives. Yes, it has shown survival benefit in breast cancer, cervical cancer, and colon cancer. So breast and cervix in women, colon in men and women, definitely screening has shown benefit. And if we have not undergone this, we should advocate and ask our relatives and near ones and dear ones to undergo screening. And to come to the population at large, it may take longer time in India because we have to improve the infrastructure. We have to have that much expertise, and it should be acceptable to the population. And we have other problems to sort out before we come on to the screening of cancer. And it is evolving and emerging role in lung cancer. Heavy smokers with 30 packages of screening, there is an evidence to show that low-dose CT scan can have benefit, but it is controversial and it should not be employed in the population. And what we should do is we should emphasize on risk factors. There is no point in doing screening, which is an expensive test or which is not acceptable or which is difficult to perform in the population, and then not emphasize on risk factors. Health education is the most important thing that we should be doing, and we should be not reassuring the people just after some tests that they do not have cancer and let them loose in the population. They should be counseled for healthy habits, and also the habit should be inculcated in the family, in the surrounding, in the neighborhood, in the city, in the state, in the country. And education is the most important thing which we should be doing, and we should emphasize on risk factors. So that's what I wanted to share regarding screening. And it is evolving field in India. There is no robust evidence to recommend any test for any cancer, for that matter, for the population. But of course, people who are interested or people who are at risk can be screened with the methods which we have discussed. There is mammogram for breast cancer, pap smear for cervical cancer, and colonoscopy for colorectal cancer, which should be done once in 10 years. So that's what I would like to say about screening. And again, once again, I'd like to thank Vice Chancellor Sir Dr. Sachidanand Sir, Registrar Dr. Ramakrishna Reddy Sir, Dr. Meera S, Professor and Head Biochem and PG Board of Studies Chairman RGUHS, and Dr. Riaz, who is the convener of this event and Deputy Director of RGUHS, for giving me this wonderful opportunity. And again, commend RGUHS staff and faculty for continuing the medical education and keeping the momentum. Thank you.
So that's a wonderful presentation on the malignancy screening. Thank you very much, sir. And the floor is open for discussion now. If anyone has a questions, they can ask.
You can ask a question or you can type in the chat.
You can ask a question, or also you can type your question in the chat box, which we'll take it up on one by one. Thank you. Thank you, sir.
Yeah, there is a question Dr. Nitya has asked. Is there a role of screening in people who have taken cervical cancer vaccine Gardasil? It's a very good question. The cervical cancer vaccine is very potent and effective and is shown to protect against cervical cancer in 98% of the individuals. But there is still recommendation for them to undergo pap smear once a year for 3 consecutive years, and then it can be done once in 5 years. But the recommendation still holds good. They still should undergo screening. That's a good question. If there are any other questions, we have 10 more minutes to go.
Dr. Shubha Jairam is typing. This red adre mute scroll down, madam. Scroll down. Another question.
There is a very important and pertinent question by Dr. Amrit Kadam. Do we have to follow screening even during COVID times? It's a very difficult question. I don't think we should be giving importance to screening at COVID times because the importance is elsewhere and we have difficult times and more serious problems. So this is for the general population during cold period and not during COVID times. I think we should refrain from screening during COVID times. But if there are symptoms, that should not be neglected and it should be brought to the notice of clinician. And of course, that doesn't come on screening. That will come under workup of the patient who is already having symptoms. And Dr. Nitya has asked, is there any role for screening for people for HCC, that is hepatocellular carcinoma? Unfortunately, no. People with cirrhosis and hepatitis B, recommendation to do ultrasound abdomen every 6 months or MRI liver, but not for the general population. But of course, yes, with people with hepatitis B and C, ultrasound abdomen every 6 months is recommended. That's a good question. When we have to screen for oral cancers in elderly people, the oral cancer screening is controversial. And some studies in South India and Northeast, they showed benefit of oral cancer screening, but it is cumbersome and it is worthwhile to advise them to stop smoking or stop tobacco. And oral cancer screening is cumbersome and it has not shown, in a larger population, it has not shown benefit. People, generally, we do not have recommendation after the age of 70 years.
Okay, I think if there are no more questions, it's my privilege to thank Dr. C.N. Patil for this wonderful lecture. You emphasized the point that cancer is a largely preventable disease and also curable disease if it is detected very early. So prevention is better than cure applies in this scenario very well. And a concerted effort from all the stakeholders and all institutes in detecting cancer at an earlier stage, either through camps or through screening camps conducted regularly, would definitely identify all the cancer patients much earlier, and they can be treated and also cured of cancer if the detection is done early. So much so that the government of Karnataka is also now thinking of implementing this by screening all women who attend gynecopedes above 30 years for a compulsory pap smear to detect cervical cancer, and also breast examination simultaneously, and oral cancer. These are 3 cancers which can be easily detected, even in regular medical checkup camps that conducted throughout the year in various places. Rajiv Gandhi University of Health Sciences also, with very small role, we have adopted the Chikballapur district where we are looking at, screening all women and looking for oral cancer, breast cancer, and cervical cancer. So such efforts are, I'm sure many other colleges must be following in different places of the state. But this goes a long way in detecting one of the most non-communicable disease, and which is largely preventable. I think your lecture has highlighted that point, and I am sure all the speakers, all the delegates would definitely take this home, take home messages, and the information that you have provided is definitely very useful. Thank you so much, Dr. C.N. Patil, from behalf of Rajiv Gandhi University of Health Sciences. We continue to choose such topics which are of general interest to all the participants, and we, as a part of this Silver Jubilee celebrations, we are looking at bringing out a compendium of all the lectures. So I would request you to submit an article of your lecture so that it will be documented forever. Thank you so much on behalf of RGHS and Dr. Meera and Dr. Reyes. We are with Dr. Shanmugappa. Thank you so much.
Thank you.
Thank you.
Thank you very much, sir.